a free paper session today. So we have our chairperson, Dr. Ajay Arora, with us. We are waiting for the other members of the panel. We have Dr. Geetanjali Sood here. So we'll be starting the free paper session now. The time allotted to each speaker is 5 minutes. Kindly stick to your time. In the end, we have a keynote address. So if Dr. Aarti is here. Yeah, okay, thank you, Doctor. So we'll have it in the end, and I would request all the participants to stay till the end so that we can have a group photograph. So we'll be starting with Dr. Natasha Radhakrishnan on psychosocial challenges in pediatric uveitis, the unseen burden.
Good morning to all. My topic is psychosocial challenges, the unseen burden in pediatric uveitis. As you all know, pediatric uveitis has a late presentation and chronic relapsing course and is potentially sight-threatening. The clinical aspects are well studied, but the psychosocial impact is definitely neglected. And because of the pediatric age group, the significant morbidity ends up in higher disability-associated life years. The psychosocial impact comes because of the affected functional vision, complicated regimens and the complications of the disease, compliance issues with school days lost, and the chronic course of the disease. In our methodology, the aims were to evaluate impact of pediatric uveitis on quality of life of the children and their parents, to identify factors that affect the psychosocial impact and quality of life, like age, gender of child, duration of treatment, and surgical interventions. It was a cross-sectional observational study. 50 children between 6 to 16 years with at least minimum 6 months of follow-up were included, and the period of recruitment was also 6 months. The assessment was carried out by administering these standardized scales: the quality of life assessment with the PEDS QL questionnaire, functional vision and eye-related quality of life with the PED IQ, the pediatric part, caregiver burden using the Zarit burden interview for parents. All questionnaires were converted to Malayalam for those not well-versed in English and were validated by back translation. All were administered in the form of personal interview by a single observer. The PEDS QL questionnaire is divided into 4 components: physical functioning, emotional functioning, social functioning, school functioning, and the items are reverse scored and transformed from 0 to 100. Higher the score, better the quality of life. The PEDS IQ questionnaire has 4 domains and is also divided by age group using a previously published rash lookup table. This was done to increase ease of interpretability. Again, higher score, better quality of life. The Zarit burden interview is to identify psychosocial impact in parents, and it is on a Likert type scale. The stats analysis were as follows. The results: 50 patients aged 6 to 16 were enrolled over a period of 6 months. The mean age was 12.26. Mean age of onset of disease was 8.56. Mean follow-up period was 9.6 months. The ratio of males to females was 24 to 26. 16 had unilateral and 34 patients had bilateral disease, and anterior uveitis was the commonest location. The JIA uveitis was the commonest type of uveitis. Associated glaucoma was present in 38 patients. 36 were on methotrexate alone, and others needed more immunosuppression and surgical intervention in 12. In the PEDS QL questionnaire, school function scores were significantly less in pan-uveitis cases, and total scores were better with younger age, better visual acuity, and shorter disease duration. There was no significant difference in scores in gender, age, age of onset, laterality, etiology, medications, or surgical intervention. In the PEDS IQ questionnaire, girls had statistically significant score than boys. Functional vision was affected in children with history of surgery and younger age, and BCVA had a weak but statistically significant correlation. There was a longer the duration of treatment, greater the frustration level in the frustration scores. In the Zarit burden, all the parents had a good score, less than 20 with little or mild stress. The median score, however, we divided into less than 8 and more than 8, and there was a significant difference based on sex. Parents with girl children had more stress than parents with boy children. In the discussion, with the advanced treatment options and better maintenance of visual acuity, Still there is problems like increased treatment cost, compliance, etc. And you need a psychosocial impact assessment for comprehensive management of these children. Why did we use 3 questionnaires? PEDS-QL has been extensively studied in chronic diseases in children, but it is not vision specific. PEDS IQ incorporates vision specific items, and DARID burden is for the parental burden. In the existing evidence, if you look at the normal threshold questionnaire, quality of life questionnaires in age-matched control, Leske et al. And Sudhakaran et al. Have studied this in children with chronic diseases, and Guerrero et al. Have studied it specifically in uveitis. So we compared our study with the Leske et al. And the Guerrero et al. Studies, and we found comparable scores in the uveitis group with 80.2 score in our questionnaire, 81.55 by Guerrero et al., compared to an age-matched normal of above 90 in the score in the PEDS-QL. The PEDS IQ reflects vision-specific quality of life, and in that also, our score is much lower in functional vision, bothered by eyes, and social and frustration worry, compared to normal that is studied by Leske and Sudhakaran et al. In the DARID burden interview, we do not have a comparison, but we have found that girl child, the parents were significantly more bothered. This may be because of the stigma associated with girl child and also concern for the future. There is a limitation to the DARID burden that many of the parents probably said a better score because they did not want to appear to be that the children were a burden to them. So there is a small bias there. To summarize, the quality of life, both vision-specific and non-vision specific, are significantly reduced in children with pediatric uveitis compared to age-matched normals. Important factors impacting the quality of life were younger age, better visual acuity, shorter disease duration, getting a better quality of life. School function was significantly affected in children with pan-uveitis, probably because of the severity of the disease. In the vision-specific quality of life, treatment duration was the one that was most significant, and increased treatment duration negatively impacts the quality of life of these children. In DARID burden, it was gender, parents of girl children being significantly more stressed than parents of boy children. This study aimed to throw light on a neglected aspect in our clinical care, the psychosocial impact a chronic vision-threatening disease like pediatric uveitis can have on the quality of life of children. We hope that the findings will help us become more empathetic and understanding in these parents and patients and become more holistic in our clinical care. These are the questionnaires I used, and these are my references. I thank you for your patient hearing.
Did you find any association with the number, like the duration of the disease with the quality of life questionnaire or with the visual acuity one?
Yeah, treatment duration had the biggest impact. The longer the duration, the lesser the quality of life.
So have you included in your study the number of months, years, and any correlation with that?
Yes, average follow-up, average time of treatment was about 9 months.
The time they had been with the disease, they had been suffering on follow-up or treatment before enrolling in your study. Did you take that treatment duration?
Yes, ma'am.
Yes.
We have taken that, and that was found to be significant.
And
in
what
the
is the average, how much duration they had been already suffering with the disease?
About 9 years.
9 years.
So Natasha, I have 2 questions. One question actually which has 2 components. One is the quality of vision that was obtained by a child, how that affected eventually your quality of life measures, if you categorize the vision of the child versus the performance of the child in day-to-day life. And second, when you use agents which allow the child to come less often back for the follow-up so that the follow-up frequency reduces, does that impact the quality of life?
First part of the question, sir, we did correlate best corrected visual acuity to the quality of life, but we did not find a significant correlation. There was weak correlation, but it was not statistically significant. About your other question, most of our children were on it's a very relevant question because most of our children were on Folitrax. Very few of them were on biologicals like adalimumab. During the time we were treating these children, first line was always methotrexate, and then when it becomes difficult, either they have multiple relapses or they present with a very severe disease, only then they were put on biologicals,
Right.
which meant more follow-up and more relapses also. Thank you.
Thank you, Dr. Natasha. Next, we have Dr. Jonathan Malcolm. Doctor will be presenting on experience with oral valcyclovir during induction phase of acute retinal necrosis treatment.
Good morning. Today I'll be talking about our experience with oral valcyclovir during induction phase of ARN. So ARN is antiviral therapy is the mainstay of treatment. Unfortunately, ARN is often unrelenting and the complication of RD often results in a poor visual outcome. So the purpose of our study was to determine efficacy of a regimen of oral valcyclovir 1000 milligrams TID along with intravitreal ganciclovir, and if using the retinal zones and clock hours of involvement can be used to plan aggressive treatment. So our study was a retrospective review. We recorded the extent of retinitis in the same way that Holland et al. Proposed for CMV retinitis. And our protocol was to use 1000 milligrams TID with intravitreal ganciclovir and prednisolone. If the macula was threatened, we would initially start with IV acyclovir at 10 milligrams TID for 5 days before starting valcyclovir 1000 mg. We chose this protocol as a patient demography cannot afford to stay for 10 to 14 days as advised in standard treatment protocol with IV acyclovir during induction phase. First dose ganciclovir was given at presentation. Number of subsequent injections were then decided based on response to treatment. All our patients were followed up till ARN had regressed. So 30 patients and 36 eyes were included. The mean age was around 45 years, equally distributed between male and females. The median duration of symptoms was 15 days before they presented to our OPD. Most of the study eyes had less than 6 clock hours of retinitis. Most of the eyes fell into zone 3 involvement, while 4 eyes had zone 1 involvement. Most of our patients were then started on 1000 milligrams TID of valcyclovir. These patients either had zone 3 or zone 2 involvement and less than 6 clock hours of retinitis. From our 30 patients, 7 patients were given IV acyclovir, and the reason it was given was they had low presenting BCVA, more than 6 clock hours of retinitis and zone 1 necrosis. IV acyclovir was given for 5 days before switching to oral valcyclovir. The mean duration of treatment was 6 months. Initial response was seen mostly within 20 days, and the median time to complete resolution was 60 days. There was a statistically significant correlation between zone involvement and time to see initial response. In zone 1, it was seen at 45 days, while zone 2 at 30 days and zone 3 14 days. However, there was no statistically significant correlation with time to achieve complete resolution. 23 of our study eyes were given intravitreal ganciclovir. In the others, the patients were not willing. The ganciclovir was given within 1 week of presentation, and in 65.2%, we noted that necrosis started healing at the 1 week follow-up visit. These eyes were given a mean injection of 1, and it was found there was no statistic significance in final BCVA whether ganciclovir was given or not. At initial presentation, 69.4% had BCVA less than 612. Unfortunately, even at final visit, most of our patients still had a BCVA less than 612. This was because of development of RRD. So 25% of our patients developed RRD, but we found no statistically significant correlation between zone of involvement, the clock hours of retinitis, or whether ganciclovir was given. After the study period, 11% had active retinitis, and final BCVA was found to be better with less than 6 clock hours of involvement. So the purpose of our study was to determine if oral valcyclovir with ganciclovir is effective and to determine if extent of retinal involvement can give a better outcome in planning treatment. Although most authors advocate 2000 milligrams TID valcyclovir, we found that 1000 milligrams was sufficient because only 6 eyes developed recurrent ARN during study period and 4 eyes had active retinitis at final visit. Zone 1 involvement took longer for initial treatment response to be seen, but zone of involvement had no statistic significance in time to complete resolution, incidence of RD and final BCVA. The median time to initial response was 20 days and complete resolution was 60 days, and this was similar to findings seen in other studies whether 1000 or 2000 milligrams was used. 25% developed RD, and these similar reports are seen in other studies as well. Lower final BCVA was led to lower final BCVA if initial BCVA was low, and if less than 6 clock hours of retinitis, final BCVA was better. So the points you would like to highlight is that oral valcyclovir 1000 milligrams provides a similar response even at compared to higher dosages. Intravitreal ganciclovir might not play a role in final BCVA. Zones and clock hours of retinitis can be used to grade ARN, and arresting to within 6 hours of retinitis can lead to better final BCVA, but this may not play a role in terms of incidence of RD. However, a prospective randomized trial could help reach a better conclusion to our findings. Thank you.
Did you give a single injection of intravitreal ganciclovir or repeat injections were required?
In some patients, repeat injections were required, especially when zone 1 necrosis was there. In some patients, those patients we had to give 3 or up to 5 injections also to see the initial response.
After what duration do you repeat them?
We would see at the 1 week follow-up visit, ma'am. If we saw response, we would not repeat. If there was no response, then we would repeat.
And
ma'am.
oral steroids, for how long did you, in all patients oral steroids were given?
Yes, ma'am. Usually we start with oral valcyclovir.
No, steroids.
Yes, ma'am. We would
Which
start
along
steroids.
same
Yes,
day,
ma'am.
okay.
Yes, ma'am.
And how long were they given? For like valcyclovir given for 6 months?
Yes, ma'am. Yes,
And
ma'am.
steroids?
Steroids, we would start tapering, ma'am.
Okay.
Within 2-3 weeks, we would start tapering and stop if we were seeing response.
Like for 1 month, 2 months, how
Yes.
long were they given?
Around a month, ma'am.
Month.
Yes, ma'am.
So you started the valcyclovir 5 days after the injection or started immediately?
When patient presented, we would start with valcyclovir, sir, and then we would do our investigations. So when the patient came for follow-up, if we felt IV acyclovir was needed, we would start. We would give for 5 days and then again go back to oral
So
valcyclovir.
supposing today you are given an injection of ganciclovir,
Yes.
when is the patient coming back for the follow-up?
They come back within 1 week, sir. 1 week follow-up, we advise. Sorry? At Arvind Hospital, sir, in Madurai.
Thank you very much. You can call the next one.
Next, we have Dr. Pushkar Dheer on sympathetic ophthalmitis following intraocular foreign body removal. After that, we'll have Dr. Kirtana Menon. Next.
Good morning, everyone. So I have a case report with the topic of sympathetic ophthalmitis following IOFB removal. The SO is a bilateral disease with panuveitis occurring after the ocular trauma. The reported incidence is approximately 0.19% after penetrating trauma and 0.01% after vitreoretinal surgeries. The pathogenesis involved an autoimmune response against the uveal antigens mediated by T lymphocytes. SO typically presents weeks to months after inciting event with decreased vision, photophobia, and redness. Usually it takes 2 weeks to 3 months to come. The aim is to report a case of sympathetic ophthalmitis following trauma and vitrectomy in a young male, highlighting the role of multimodal imaging and early steroid use. The case is about a 24-year-old male presented with open globe injury to the left eye, which was an exciting eye, following a burst cycle tire. The BCA was 6.6 in the right eye and perception of light in the left eye with projection of rays was accurate. On examination, the anterior chamber had an hyphema of 5 mm with corneoscleral lacellation with uveal prolapse and IOP of 7 mm. And B scan was suggestive of high refractive echoes at the posterior pole, which was suggestive of RD but inconclusive of any intraocular foreign body. So we repaired the trauma with the patient underwent basically a 10-0 corneoscleral repair with a 10-0 nylon sutures and followed by a 25 gauge PPV, endolaser and PFCL. In the intraoperative findings, we had scleral tear with vitreous incarceration, iridodialysis, and a maculochoroidal rupture were noted. Metallic foreign body particles were removed during the scleral repair, but no IOFB was noted per se. On the follow-ups, 2 months, removal of loose corneal sutures were done, and AC was well formed with visible choroidal scar at the macula. But what happened in the right eye was there was circumcorneal congestions with cells 2+ and vitritis. That was the eye which was actually ignored, but patient came up saying that my right has a reduced vision. And once we did the examination, the fundus examination showed that there was exudates, SRF pocket, and macular edema with dull foveal reflex. OCT demonstrated neurosensory detachments with subretinal hyperreflective material, and FFA showed the pinpoint leakages, confirming it as a sympathetic ophthalmitis in the sympathizing eye. We started the patient on straight away with IV MP 1 gram per day for 3 days, followed along with topical prednisolone, napafinac, and hometropine. And after 3 days follow-up, the patient vision improved to 6.9, the cells were reduced, and we continued on the topical medication along with the systemic medication. And finally, the patient recovered after a period of a month. So my takeaways from this case was most cases develop sympathetic ophthalmitis within 3 months of the injury. It's usually 2 weeks to 3 months. Diagnosis may be delayed due to its similarity to idiopathic uveitis or VKH. Multimodal imaging like FFA and OCT is required. Rosveska et al. Reported that OCT changes may precede over the clinical features. Prompt initiation with high dose of corticosteroids is the cornerstone of management. The main differentiating diagnosis is VKH, which causes bilateral granulomatous uveitis, but is typically associated with systemic features. Ton et al. Noted a recurrence in 71% of cases in a series of 130, underscoring the need of a long-term monitoring, maybe till 8 months to 1 year. Recurrent or refractory cases or maybe steroid-sparing immunosuppressants may be required in a long term. Thank you.
You mentioned that you did suture removal at 2 months, and then the patient developed in the other eye redness.
Yes, ma'am.
How many days after the suture removal did that happen?
Ma'am, he presented around a week after the suture removal.
On the day of suture removal, the eye was quiet.
Maybe it was quiet, but my more focus was on the suture removal, and he was slightly experiencing a decreased vision in the right eye, but that went unnoticed on the very first visit of the suture removal.
So maybe he might be having some inflammation.
Correct, yeah.
And did you give oral steroid at the time of initial trauma?
At the time of initial trauma, at the first visit itself. So the day the patient presented, I repaired on the same day itself, and he was started only on the topical steroids, not on oral steroids. Yeah.
So I have just 2 questions for you.
Yes,
Did
sir.
you get a CT scan done initially for the...
Sir, for all IOFBs, no, I don't get CT scan done.
I think for any patient who is suspecting an IOFB, CT scan maybe on a long-term medico-legal thing becomes mandatory, and you should get a scan with thin
Orbit.
slices so that you don't miss a small intraocular. Because in your presentation you stress 2-3 times that there may be an intraocular foreign body.
Yes.
So what did you do for that maybe? You should ideally do a CT scan to make sure that there is no MRI, because you can displace
Yeah,
a
that
metallic.
is correct.
You should get a CT scan done. And second, is the patient still on a follow-up?
Yes, sir.
So
he-
that is important, because even though you have treated, this patient can have
Can- yeah, yeah.
recurrences. So you must keep the patient for
He's on continuous follow-up, sir. Thank you.
Abdullah.
Next speaker is Dr. Soumya. She'll be presenting on ocular clues to diagnose sarcoidosis, a case report.
Dr. Kirtana.
आप मार्क कर दो ना इसको. We should do a combined mark. whatever you feel.
Good afternoon, everyone. I am presenting my paper on the topic ocular clues to diagnosing sarcoidosis. I am presenting a case of a 51-year-old woman presented with complaints of headache since 1 week. Her uncorrected visual acuity was 6/24 and near vision was N24 in both eyes. Her best corrected visual acuity was 6/9 and N6 in both eyes. Color vision was 15/15 plates in both eyes. IOP measured using rebound was 10 in the right eye and 11 mmHg in the left eye. On examination, the anterior segment showed mild conjunctival congestion with anisocoria and grade 2 RAPD in the left eye. On fundus examination, she had bilateral disc edema. Suspecting some neurological etiology, neurology opinion was taken. MRI brain was done, which showed few lacunar infarcts with a normal MRV study. 2 weeks later, the patient came to the OPD with bilateral upper lid edema and conjunctival congestion. IOP measured using rebound was 14 in the right eye and 12 in the left eye. Anterior chamber showed 3+ cells reaction with flare. Posterior synechiae was there with iris pigments on the lens. Fundus examination showed bilateral disc edema with signs of vitritis. There were also snowball opacities in the inferior vitreous, and candle wax dripping sign was also seen in the inferior quadrant. Her visual acuity remained the same as the last visit. These features were suggestive of pan-uveitis, and she was started on topical antibiotics, steroids, NSAIDs and cycloplegic agents. OCT macula which was done showed normal foveal contour, which was central foveal thickness was 225 in the right eye and 229 in the left eye. Uveitis workup was done for the patient. Mantoux test, sputum AFB culture, CB-NAT and quantiferon gold TB were all negative, ruling out TB. Chest X-ray also was grossly normal. Serum ACE was 67 international units, which was slightly elevated, normal being 8 to 52. CCT thorax showed focal consolidation in the right middle lobe of the lung, subpleural multiple fibrotic nodular pattern lesions with bilateral hilar and mediastinal lymphadenopathy. Bronchoscopy showed no endobronchial mass. USG neck and abdomen were normal. Small size biopsy of the lung showed tissues lined with respiratory epithelium with focal mucus glands. Serology and VDRL was negative. These investigations were suggesting towards sarcoidosis, and the patient was referred to rheumatology for further management, and she was continued on our top medications. On our 2 months follow-up, the patient was doing symptomatically better. Her uncorrected visual acuity was 6/12 in the right eye and 6/18 in the left eye. The anterior chamber was quiet and there was broken posterior synechiae. Fundus examination showed signs of resolving disc edema with mild vitritis features. This is a photo captured using fundus camera showing broken posterior synechiae. Her fundus photo which showed disc edema. Discussion. Sarcoidosis is a heterogeneous granulomatous systemic inflammatory disease characterized by the presence of non-caseating granulomas in tissues. Ocular sarcoidosis is seen about 10 to 55% of the sarcoid patients, sarcoid uveitis being the most common ocular finding. This conclusion, this case underscores the significance of recognizing uveitis as a possible early indicator of systemic sarcoidosis. Prompt recognition and systemic evaluation are crucial for appropriate diagnosis and management. It also emphasizes the importance of interdepartmental collaboration for timely diagnosis and treatment. Thank you.
So you told you had grade 2 RAPD at the time of presentation. So the visual acuity at presentation was almost 624, 618. So how do you explain RAPD in left eye? Because vision is almost similar.
Yes, that time she didn't have any retinal involvement also. She just had mild vitritis features. Candle. Disc edema was examined. Both eyes she had bilateral disc edema and mild feature of vitritis.
And vision was almost same in both ways.
Age was 624, uncorrected was 6 by 24.
So either the finding is wrong or something must be there for RAPD. So it is, there should be significant difference in the edema or the visual acuity. Then only you can explain this RAPD. And what is unique you want to highlight? What are the unique points in your case? What do you highlight it from your case?
Ma'am, initially when she presented only with papilledema, we thought of some neurological cause, but since everything was normal and her 2 weeks follow-up, she had a very drastic change. Her there was anterior segment reaction and all, so that's why we were she presented with full pan uveitis in her 2 weeks follow-up.
During the course of time, initially anterior segment
Initially
features
she
were
had
not
no,
there.
ma'am. She
Okay.
had no signs.
Thank you. Yeah,
It's biopsy proven. Small line biopsy.
Yes, ma'am.
Or
And
maybe
the
it's an
HRC
incidental finding which is there of raised serum ACE. There's no histology also for that. The bronchoalveolar lavage has also not been
It's
checked.
a presumptive case.
Yeah, so we have definitive, presumptive,
Presumed.
and probable. I think the IVOS criteria is the least we can probably label it as a case of.
Yeah, so
because
I
there
think-
shouldn't be any RAPD per se in the case of sarcoidosis anyhow. And there's no candle wax dripping, no granuloma. Just on basis of snowball opacities, I don't think we can label it as sarcoidosis. Maybe
Agree.
probable.
Yes, ma'am.
They have reported
Can-
candle wax dripping.
Sorry?
And even biopsy was done, lung biopsy.
Biopsy.
In HRCT thorax, it showed bilateral mediastinal lymph nodes, hilar and mediastinal lymph nodes. And also on the biopsy, it showed inflammatory cells with mucus glands.
So was it written a case of, looks like a suggestive of sarcoidosis?
Yes, sir, it was suggested of
Then it will be a
sarcoidosis.
definitive. If biopsy is true, then it is definitive sarcoidosis, but with very less findings.
So I think what he's trying to point out is that you should categorize your case as a probable, presumptive, or the definitive diagnosis by the criteria which you have, and try to explain all these things, that why you think it's a case of sarcoidosis.
There is a criteria for sarcoidosis, IWOS, some criteria 2019, some criteria is there which define it in 3 things.
Yeah, but for
Sir,
the
I
case
think,
presentation, I don't think we need to go into all that. She can just say that.
I think it might fall under definitive, sir, because HRCT thorax also had
Yes.
lymph nodes as well as biopsy also showed
Yes.
flu inflammatory
So the
cells.
definitive case of sarcoidosis.
Definitely.
Thank you. I think let's go to the next presentation. Thank you very much.
Next, we have Dr. Ankita Chaudhary. Dr. Ankita Chaudhary is here. Dr. Asmita Rastogi. Dr. Asmita Rastogi will be presenting on iris pigments deposition over anterior lens capsule, a novel biomarker for acute HLA-B27 uveitis. And next, we would have Dr. Anupama. Next, after that.
Good morning. So today I'll be talking on iris pigments on the anterior lens capsule as a non-invasive biomarker for HLA-B27 associated anterior uveitis. So I'll be talking on the topic under the following headings. As we know that uveitis is a diverse group of intraocular inflammation and has variety of subsets, and is also a major cause of visual morbidity, causing 10% of preventable blindness in the developed countries. Anterior uveitis is the most common subset and has heterogeneous etiologies ranging from infectious, non-infectious, granulomatous to and non-granulomatous as well. HLA-B27 associated uveitis is also a clinically significant form and has been often reported as the most common non-infectious form of anterior uveitis worldwide, and is characterized by severe inflammation, higher chances of recurrence, causing not only ocular morbidity but also systemic morbidity due to its strong association with seronegative spondyloarthropathies. So ophthalmologists are often the first point of contact for these patients, the first point of detection for HLA-B27 antigen, therefore we need reliable ocular biomarkers to diagnose it. Even though the burden of anterior uveitis is more with infectious causes, but a number of studies conducted in different parts of the country are showing that even HLA-B27 uveitis is contributing significantly to the disease, which is why we are conducting this study to evaluate the presence of iris pigments on anterior lens capsule as a non-invasive clinical biomarker to identify HLA-B27 uveitis. We conducted a prospective case control study, and using a cohort of 52 eyes, where 26 were cases which were diagnosed cases of HLA-B27 positive uveitis, and 26 eyes which were controls that were cases of anterior uveitis, the non-infectious kind, but were non-HLA-B27 positive. And all of them underwent comprehensive ophthalmological examination. What we found correlated with the findings that have been known, that is the younger cohort, the younger age group among the cases, which is also demonstrated in this box and whisker plot. The aggressive inflammatory phenotype as compared to the other non-infectious forms of uveitis, anterior uveitis. Our novel biomarker was present in all the cases of HLA-B27 and only in 50% of the control group, showing a sensitivity of 100% and a negative predictive value of 100%. So using this sensitivity and negative predictive value, we can safely assume that if the iris pigments are not present on the anterior lens capsule in a patient of anterior uveitis, we can consider that the patient might be negative for HLA-B27 positive. A receiver operating curve was also plotted to calculate the area under it, that came out to be 0.75. So this was plotted to find out the discriminative ability of the biomarker, that came out to be moderate. So neither it is a perfect biomarker, but it does have some meaning in ruling out other causes of uveitis. So these are some clinical photographs of our patients. As we can see that it presents with a severe and aggressive inflammatory phenotype, and post-midricaine injection it showed remarkable reduction in congestion, the anterior chamber reaction, but the iris pigments still persisted. Then in our cases, the iris pigments persisted long beyond the active inflammation subsided. So from this we can conclude that it is a highly sensitive biomarker, but it has moderate specificity and has strong diagnostic association, especially to exclude B27 uveitis when it is absent. And these findings echo other studies as well that have reported iris pigments more over the HLA-B27 cases, and therefore iris pigments can be used as a useful diagnostic clue to diagnose the HLA-B27 uveitis. The pathogenesis could be due to the aggressive inflammation. There is iris lens contact causing the pigment epithelium to rub against the lens capsule, which causes the deposition of pigments. The useful thing is that the pigments will persist even after the inflammation resolves. So it is not just a marker of an active disease, but also a retrospective marker of prior inflammation. Despite its moderate specificity, it is still valuable because it raises our suspicion, and we can it can guide targeted testing, and is also useful in resource limited settings. So it is a novel, simple and a non-invasive slit lamp sign that is practically useful bedside settings and resource limited settings to enable early diagnosis, systemic evaluation, timely referral to the rheumatology department so that we can start the systemic treatment for the patient as well. Thank you.
Very interesting observation. So, which means that if I see a patient who has got iris pigment, I can say whether it is HLA-B27 positive or negative?
No, sir, not with just the iris pigments, but we also have to take in the account the other anterior segment findings. We also have to see the patient as a whole, having history of spondyloarthropathies or lower back pain, morning stiffness. So taking all of this into account, we can suspect that the patient might be positive for B27.
So these are the days of AI. And
Yes,
AI, you feed in all this data and then you tell, okay, this is a picture of pigment on the iris. The AI will tell you that this is actually B27 positive. Is that a marker, something like that?
No, sir, it cannot. Nothing can rule out the presence of the antigen on the WBCs, but it can be effectively used to rule out the negative cases.
Why do you think iris pigment sticks in case of HLA-B27 versus which are not B27 positive? Why do they stick to the lens surface? You have any theory behind it?
So possibly because there is protein misfolding and
So that is happening with any
mimicry.
uveitis.
Yes, sir. So that causes much more severe and an aggressive inflammation. So that causes release of much more iris pigments, possibly because of that there's presence of the pigments.
Did you note any
Ma'am, they were not included in our study because we took all the non-infectious patients. But what we've seen over the course is they were more patchy, or they were more broad depositions and coarse depositions, and not fine depositions as Yes, ma'am. They're more finer towards the center, and so that was different as compared to viral uveitis. Thank you, ma'am. Thank you, sir.
Tell you this, we had done some study in this almost not 28, 30 years back, that any pupil you dilate, any pupil, especially over the age of 45, there is a pigment release. This is not related to uveitis because that time we were working on cases of pseudoexfoliation, and we had considered iris pigment release and changes in the iris in cases of pseudoexfoliation. So there is a table available with a grading score of how much pigment gets released, and that you could probably incorporate it in your studies in the future. Just a suggestion.
Yes, sir. Thank you, sir.
Next is Dr. Anupama, 10-year follow-up of a patient with VKH disease. After that, we'll have Dr. Tarita Biswas.
Very good morning to all. So this is a case report of a 10-year follow-up of VKH. So this lady presented to us in 2012. Her vision was 6/6. She said that she had received intravitreal injection a month back for some condition in the eye, and subsequently she reported to us in April. She reported to us with blurring of vision. She was found to have choroidal lesion and disc edema, for which she was receiving systemic steroids. So while she was on tapering steroids, there was recurrence of the disease. IV methylprednisolone was given, followed by maintenance of steroid. She was lost for follow-up for a year, and she came back with disc pallor. And in July, so every year she had some kind of a inflammation in the eye. So we started her on methotrexate in 2015, though her disease was she had a disease in 2012. And subsequently she said that she wasn't very compliant with the treatment, and every year she had some form of a non-granulomatous anterior uveitis and choroidal lesion, though her vision was maintained at 6/6. In 2022, she noticed vitiligo. That's when she said she stopped methotrexate completely, and she had worsening of the disease, and she developed sunset glow fundus. So basically, this was the first visit. This is even before she had reported to us. She was given anti-VEGF at this time, and you could see that there is some amount of choroidal lesion and disc edema. This was subsequently in 2012 with choroidal lesions and leakage, subretinal fluid, and disc edema. So these were the subsequent inflammation images when she had subsequent inflammations. So we know that VKH is an idiopathic autoimmune disease, and which is bilateral granulomatous with serous detachment, disc edema, and vitritis. It is important that early diagnosis is an absolutely a must, and we see that the early diagnosis would be about in what we would see is choroiditis, subretinal fluid, and disc edema. So basically, early introduction of systemic steroid and gradual tapering is absolutely a must. So there was a study which they had gradually tapered systemic steroid, but there was recurrence of the disease, and it is recommended that the immunosuppressive to be started at least within 2 to 3 weeks, and of course you could also start it immediately to prevent sunset glow fundus. So in our patient, she was on systemic steroid. There was recurrence because of when the steroid was being tapered, and there was delay in initiation of the immunosuppressive drug. And early introduction of immunosuppressive is absolutely a must. You could use either mycophenolate mofetil, you could use azathioprine, which has been published in an Indian study, and of course methotrexate is also is as effective as mycophenolate mofetil. So you could use any of the immunosuppressive drugs. a chronic BKH, which is what we saw in our case, there could be subclinical inflammation which would go unnoticed, and this would end up with sunset glow fundus. So in our patient, chronicity was documented, there was recurrence of the disease, and this was because of inadequate immunosuppressive drug and also possibly non-compliance. So sunset glow fundus should never ever happen in a case of VKH if the immunosuppressive is sufficient, and it was usually seen in patients who discontinued immunosuppressive drugs and where the immunosuppression wasn't very adequate. So it was also told that though the patient is absolutely fine, there could be some amount of subclinical choroidal inflammation happening, the patient would have anterior uveitis, and there could be also minimal subclinical choroidal inflammation happening. So in our patient, there was sudden flare of vitiligo and sunset due to discontinuity as well as inadequate immunosuppressive drugs. So the learning point is early diagnosis and prompt diagnosis of VKH is a must, while you're tapering steroids, and in addition to these steroids, immunosuppressive to be started by 2 to 3 weeks. Switch to another immunosuppressive drug, or you could add an immunosuppressive drug in case of recurrence, and watch for subclinical choroidal inflammation. And it's absolutely important to consult the patient on each visit about the importance of continuation of the drug. Thank you.
What was the diagnosis on the first visit when you...
Yeah, so initially, actually, I got a B scan done. I could see T signs. So initially, when she came to us, she had already received intravitreal anti-VEGF injection. When she came to us, her vision was 6/6, and the second month she came to us, she had choroidal lesion. I got a B scan done. I did a MAN2, which was negative. I thought it was posterior scleritis, but subsequently, when she had recurrence, I did a MAN2, which was strongly positive. I also got an HRCT done, which was negative. So initially, I thought it was posterior scleritis, APMP, but then it was VKH.
You didn't do FFA that time?
Yeah, I did FFA.
Initially?
Yeah, it was there. There was hyperfluorescence, there was subretinal fluid, all signs of VKH was there. That was 10 to 12 years back.
So your patient had unilateral presentation?
Yeah, she had actually, it was not, it was unilateral, and it was each eye each time. You know, it wasn't the same eye all the time, but she never had a bilateral presentation. Possibly she had a subclinical inflammation in the other eye which was not detected.
Okay. But the left eye was always more affected?
Yeah, it was unilateral. And it was also suggested that it is better to follow up these patients on ICG to pick up subclinical. We do not have an ICG facility in our hospital, or you could always do an enhanced depth imaging OCT to look at the subfoveal choroidal thickness.
So how often do you call her for follow-up?
Actually, I would call her up frequently, but she would come when she could feel something in the eye.
Okay.
And most of the time she was not here, she used to be abroad.
Okay.
Yeah, thank you.
Okay, next we have Dr. Tarita. Congenital ectropion uvea with ptosis. After that, we'll have Dr. Vaibhav Chaudhary.
Good morning. Today I'm going to present congenital ectropion uvea with ptosis. There is no financial support or sponsorship. There is no conflict of interest. Congenital ectropion uvea is a rare anomaly associated with various systemic and ocular conditions. We report a series of 3 patients presenting with congenital ectropion uvea associated with ipsilateral ptosis and glaucoma. Association of CEU with craniofacial defect is also seen in one of our cases. Case 1, a 12-year-old girl presented with gradual loss of vision in left eye associated with drooping of left upper eyelid for 8 years, associated with enlargement, outward protrusion, photophobia of the left eye. On irregular basis, she was using topical beta-adrenergic blockers that was prescribed elsewhere. On examination, vision in left eye is reduced to hand movements close to face with proptosis of 17 millimeters in Hertels, and on Goldman applanation tonometry, IOP was 48 mm of Ag in left eye. 2 mm ptosis with good levator function was seen in left eye. In right eye, slit lamp examination was within normal limit. In this picture, we can see there is drooping of left eye, left 2 mm ptosis. On further examination, left eye pupil is round with anisocoria and 360-degree ectropion uvea, which is also shown in the following images. Right eye has normal findings. On gonioscopy, left eye has anterior insertion of iris, which is noted in all the quadrants. Fundoscopy reveals glaucomatous changes in near total cupping in left eye, shown in the following image. Initial medical treatment was given. IOP was reduced to 32 mmHg and vision improved to finger counting 1 meter. Patient refused surgery that time and was not, controlled medical treatment was given. But after 1 month follow-up, IOP was not getting control and it still remained 40 mmHg. So left eye trabeculectomy with mitomycin C was planned and IOP reduced to 18 millimeters Hg and vision improved to finger counting 2 meters. Case 2, a 15-year-old male presented with progressive diminution of vision in left eye and headache for last 1 year. History of previous surgery of cleft lip and cleft palate was done at the age of 4 months, shown in this picture. And the patient was already under treatment with bimatoprost and pilocarpine in left eye for last 1 year. Vision in left eye was 6/24 and right eye was 6/6. IOP by Goldman applanation tonometer was elevated, that is 34 mm mercury, on 2 anti-glaucoma medication. Right eye showed normal findings. Left eye had 2 millimeter ptosis with good levator function. On further examination, 360-degree ectropine UVA was seen in left eye. Gonioscopy shows high insertion of iris without any synechia in left eye, also shown in the following images. And right eye has wide open angles with normal fundus features. Left eye has glaucomatous fundus changes, shown in the image. Management, left eye trabeculectomy with mitomycin C was performed and IOP was controlled, 10 millimeter Hg it was maintained and no further loss in visual field and IOP was noted. Case 3, a 5-year-old girl presented with redness in right eye for 10 to 15 days, not associated with discharge, watering, photophobia, no history of trauma. In right eye, vision was reduced and IOP was measured with non-contact tonometer, 48 millimeters of mercury. 2 mm ptosis with good LPS function was seen in right eye. Left eye had normal findings, also seen in the following image. And in pupil in right eye was mid-dilated fixed with 360-degree ectropion UVA, and in fundus examination, glaucomatous changes were seen with almost near total cupping and bayoneting of vessels. Management, IOP was controlled with oral and topical anti-glaucoma medication and patient was immediately advised for both eye examination under anesthesia and right eye trabeculectomy with mitomycin C. On discussion, congenital ectropine UV is a rare non-progressive neural crest cell disorder. Progressive open-angle glaucoma may be associated due to dysgenesis or endothelialization of the anterior chamber angle. Neural ectodermal origin of Mueller's muscle explains the presence of mild ptosis with good levator function in our patients. Glaucoma filtration surgery with or without antimetabolite is treatment of choice for glaucoma. After surgery, patient was benefited symptomatically and cosmetically with improved in vision. Retrospectively, patients presented with ptosis should be evaluated for CU and glaucoma for early diagnosis. Thank you.
So how often have you must have read about it, how often has the association been reported?
Ma'am, congenital ectropine UV, it is usually a rare presentation, usually unilateral. Often it gets missed and bilateral, it's rare, very rare, but it's a rare phenomenon.
And
Congenital
association with ptosis?
association, I have seen 5 patients till now.
5
Yes, ma'am.
You read about 5 cases till now.
Like in, I have seen patients.
No, the 3 cases you have reported, have they been reported?
At that time, it was when I wrote this, it was 3. After that, it was in some patients like neurofibromatosis also it was associated in one patient, and one patient had like this had craniofacial defect. Other patient, there was no such as finding.
But in your patient, no neurological association was seen in 3
one
of
patient, as I've mentioned over here, it has craniofacial defect,
Okay.
and another patient I've seen that has neurofibromatosis associated, and other had no such systemic associations. Rest were
Next is Dr. Vaibhav Chaudhary on endogenous endophthalmitis in ICU patients at a tertiary care center in Western UP. After that, we'll have Dr. Kushagra Varshney.
Good afternoon, everyone. The topic of my paper is endogenous endophthalmitis in ICU patients at a tertiary care center in Western UP. Endogenous endophthalmitis is a rare but vision-threatening intraocular infection caused by hematogenous spread of pathogens from a distant systemic foci. This condition possesses a significant diagnostic and therapeutic challenge, particularly in critically ill patients admitted to ICU, where multiple risk factors such as immunosuppressions, prolonged hospitalization, invasive procedures, and indwelling catheters are prevalent. In India, especially in a tertiary care center in regions like Western Uttar Pradesh, the true incidence and clinical characteristics of endogenous endophthalmitis among ICU patients remains always underreported. So the purpose of our study was to determine the incidence, predisposing factors, comorbidities, spectrum of causative organism, and outcome of endophthalmitis patients who are admitted in an ICU of multiple departments. It was a prospective observational study conducted over a period of 1 year from January 24 to December 24 at a tertiary care center in Western Uttar Pradesh. Patients who were included in the study were the patients who were admitted because of their critical illness in ICUs of multiple departments like medicine, obs gynae, general surgery, and orthopedics, with the clinical suspicion or diagnosis of endogenous endophthalmitis. All of the patients were having an age of more than 18 years. Patients who were not included were patients who were suspected of having any of the exogenous cause because of any history of ocular surgery or a trauma or preceding injections. And also the pediatric patients less than 18 years of age were also not included because of the other risk factors. And patients who were having an incomplete clinical records or refusal for ophthalmic evaluation because of the critical illness were also not included. The data recorded were about the demographic information, primary diagnosis for admission, presenting ocular symptoms and signs, blood and intraocular fluid culture results, lab investigations, general lab investigations, the treatment given, systemic and intravitreal injections both, and visual and systemic outcomes. During this 1 year period, we were reported about 31 cases of endogenous endophthalmitis among 12,500 annual ICU admission, resulting in an incidence of 24.8 cases per 10,000 admission, corresponding to an incidence of 0.248%. 29 patients were having monocular involvement, but unfortunately 2 of them developed the other eye involvement later. Maximum number of patients were having a TLC count of more than 15,000, followed by 10 to 15,000. Maximum number of patients were having an associated illness being diabetes mellitus, followed by the HCV infection-induced chronic liver diseases, which is very prevalent in this Western UP belt, followed by the patients with CKD. Few patients were having malignancy and they were on chemotherapy. 2 patients were having immunosuppression, were immunosuppressed because of HIV infection, and 3, there was no any associated long-term associated illness. When the vitreous and aqueous culture was done for microorganisms, the 30 maximum number of patients were having a MRSA, methicillin-resistant Staph aureus, as a positive, followed by the Streptococcus bacteria. 4 patients, all of them were diabetic, were having Klebsiella as a positive bacteria. 3 patients were having a mixed growth of both positive and negative bacteria. 2 patients were positive for Aspergillus, and 1 of them showed Candida species. When the ICU duration was assessed, maximum number of patients were having an ICU duration of more than 21 days, followed by 15 to 21 days. Means maximum number of patients were having an ICU duration of more than approximately 2 weeks. Patients were having an ocular manifestation, maximum number of patients were having a decreased vision, and because this is the reason they were asked for reference by their respective departments. Many patients developed lid swelling, conjunctival congestion, corneal haze, and because of corneal abscess. 19 patients were having hypopyon, and followed by purulent ocular discharge and chemosis. They were managed according to EVS study. We performed vitrectomy on patients with vision only, perception of light or less. They were 25 patients, and they were given along with intravitreal antibiotics. We performed the vitrectomy on these patients, and majority of them were diabetic. Intravitreal antibiotic injections of vancomycin and amikacin combination were given in 28 patients, and 3 patients who were positive for fungus, they were given an intravitreal voriconazole injection. And since it was an endogenous cause, all of them were receiving already intravenous systemic antibiotics. After the first intervention, we assessed the visual acuity after 60 hours, and it was assessed that 3 patients were improved from more than hand movement. So this study underscores the critical importance of early recognition and targeted management of this endophthalmitis in ICU settings, a rare but sight and life-threatening condition that is often overlooked amid critical illness. So this is to initiate that ICU admitted patients should have a mandatory ophthalmic reference every week for early evaluation of any eye involvement, which is usually ignored amid critical illnesses. Thank you.
In the patients you have done vitreous, you have sent the sample for microbiology, vitreous sample.
Vitreous samples.
And was there any agreement between that and the blood culture if was done in the ICU?
Yes, ma'am. Those patients who were positive for blood culture, like for fungus, candida, and Klebsiella in patients में positive था, patients में vitreous samples में भी Klebsiella मिला है. Especially, so there was a strong correlation between the blood culture reports and the aqueous and vitreous culture reports. So this indicates that the infection may come is probably from the primary foci, which is somewhere else in the body. So many of the patients were having a pneumonia and chronic liver abscess as an associated illness. So it was very difficult for those critical patients who were admitted in ICU to make them shift to in IOT and convincing other departments. So it was very difficult, but it was just to create awareness among other department also that they should send the reference for ophthalmology if the patient is admitted in an ICU, so that in case the patient recovers, those vision deteriorate now in future life.
So what % of cases had like systemic same organism or sepsis associated with who developed endogenous endophthalmitis? All patients were having sepsis or
Ma'am, all of them patients were having bacteremia or
some kind of sepsis was there, and similar organism from like other sites and ocular sample.
Ma'am, maximum number of patients were having similar organisms.
You
Same
did not
class,
calculate
gram-positive bacteria. Maximum number of patients gram-positive bacteria.
So they must already be getting antibiotics.
IV antibiotics they were receiving.
This you should mention the percentage, like what was the percentage of patients who were actually getting similar in bodies, any other side sample and in ocular sample.
Yes,
and whether you changed antibiotics for that or not.
When we performed the we gave the intravitreal antibiotics according to the guidelines.
That was for ocular sample, but
ocular.
Systemic also they must
systemic
be
they were all already receiving antibiotics.
And all were ICU cases.
And all of them were ICU patients.
Dr. Kushagra. Dr. Vaishnav will be presenting on pattern of anti-uveitis in a tertiary care hospital in the region of Delhi NCR. After this, we'll have the keynote address by Dr. Aarti Rajkumar.
So very warm and golden good morning to everyone. Today Dr. Kushagra Vaishnav would like to present on the pattern of anterior uveitis in the tertiary care hospital in the region of Delhi NCR. So introducing to the topic, anterior uveitis is the most common cause of the intraocular inflammation, and it is its etiological pattern varies in different countries across the globe. It causes reduction in the vision during the acute stage, but if left untreated, it results in potentially severe visual consequences. So anatomically, it is divided according to the inflammation of the iris, which is iritis, anterior part of the ciliary body, that is anterior cyclitis, and if both the structures are involved, then iridocyclitis. It is more common than posterior segment inflammation, but is less serious and less sight threatening if treated early. So if diagnosed and treated on time, anterior uveitis can be treated without long-term sequelae, and even if there is associated complications, they can be promptly treated if detected early. Now, since the pattern of uveitis is different in various geographical regions, discovering these patterns would be helpful for diagnosis and treatment of this broad category of the condition. So aim was to study the pattern of the anterior uveitis in a tertiary care hospital. The patients included were the patients having anterior uveitis of all etiologies, the patients with the previously diagnosed or the known cases of the anterior uveitis, patients having chronic anterior uveitis were included. The patients that were excluded were the posterior uveitis patients, patients with a recent history of any intraocular surgery, or the patients having masquerade syndromes presenting as anterior uveitis. So the study included a prospective cross-section study where 100 patients were involved with anterior uveitis in the outpatient department of the hospital over a period of 1 year from June 23 to May 24. The following step-ladder approach was undertaken. Detailed history was taken in terms of the onset and the progression of the symptoms, course of the treatment received, and the emphasis on the corticosteroid therapy was noted. Past ocular history eliciting recurrent attacks of the uveitis and previous responses to the treatment were also noted. Physical examination was done to rule out any systemic association in relation to the history, and slit lamp examination was done. On slit lamp examination, various signs that like hypopyon, anterior chamber cells, meiosis, ciliary injections, keratic precipitates, iris nodules, iris atrophy, and aqueous flare and posterior synechys were noted. So, as per the results, the age group that was more reluctant, that received more uveitic cases were the second decade, about 40% of the cases. In third decade, about 26% of the cases. Fourth decade, about 10%. In fifth decade, 8%. Sixth decade, 8%. Seventh decade, about 3%. In the extreme of the ages, around 1% of the cases. As per the distribution, the acute case presentation was found in about 72% of the cases, whereas in chronic presentation, about in 20% of the cases, and recurrent were about 8% of the cases of the total presentation. When we talked about the gender predilection, the males were affected more, which is about 61% of the cases, and females about 39% of the cases. If we talk of the etiology, idiopathic causes was the most found to be about 44% in the patients. Blunt trauma in about 25% of the cases. HLA B27 predilection in 10%. Herpes and tuberculosis at 6% and 2%. Fuchs heterochromic iridocyclitis in about 4% of the cases, and spondyloarthropathy in 4%, and the juvenile idiopathic arthritis in 3% of the cases. Several complications were also noted, out of which 40% of the cases developed no complications. About 26% of the patients developed persistent posterior synechy. 18% cases developed cataract. Around 10% cases developed secondary glaucomas. In 4.4% patients developed iris atrophy, and 1.7 patients were noted with macular edema. So summarizing, the incidence was found to be highest in the second decade, around 40%, and the least was found in extremes of the ages beyond 8th decade, about 1%. Idiopathic anterior uveitis was found to be the most common cause. It was observed that the males were affected more and than the females, which also related with the Rathimanam study with the similar findings. The most common presentation was acute iridocyclitis with 72% cases, chronic being 20%, and recurrent cases being 8% only. The most common complication observed was posterior synechy, about 26%, and cataract in about 18% of the cases. So, concluding, the early diagnosis and the treatment of the patients result in good visual prognosis and the key to the management of the anterior uveitis. And since the uveitic entities follow different patterns in different regions, influenced by a variety of the factors, epidemiological studies can help improve their diagnosis and the treatment. These are the references. Thank you.
Were your results different from the already reported literature statistics?
Ma'am, this was a novel study. The study I quoted was a different region other than the global, other than the NCR. But the results in the Indian subcontinent were more or less the same as the bacterial causes and the infective causes, and the were found to be more common. Idiopathical causes were also very common, but this study promotes that we need to research more on the etiological factors so as to identify the idiopathic causes, which is more prominent into the dominant population. Thank you so much.
Thank you, Doctor. So we'll end up the session with the keynote address by Dr. Aarti Rajkumar on clinical profile of patients with uveitis developing peripapillary choroidal neovascular membrane.
Good afternoon to one and all present here. The topic is clinical profile of patients with uveitis developing peripapillary choroidal neovascular membrane. Inflammatory CNVM is a dreaded complication associated with intraocular inflammation. Peripapillary CNVM is characterized by formation of new vessels between the inner collagenous layer of the Bruch's membrane and outer sensory retina located within one disc diameter of the margin of the optic nerve head. Because of the anatomical location, peripapillary CNVM can be asymptomatic initially and become symptomatic with macular involvement. They are usually occult membranes and can pose significant diagnostic and therapeutic challenges. Coming to the methodology, it was a retrospective analysis conducted in a uveitic clinic of a tertiary eye hospital between January 2015 to December 2019. Patients with inflammatory peripapillary CNVM were included in the study, and patients with CNVM due to other causes like trauma or degenerative diseases were excluded. All patients underwent comprehensive eye exam and ancillary laboratory testing to rule out underlying systemic etiologies. OCT angiography was done to look for the CNVM, and all patients were treated for an active peripapillary CNVM with intravitreal anti-VEGF injection, which was repeated every 3 to 4 weeks. Patients were followed up every month till the activity of the CNVM subsided. Coming to the results, 29 eyes of 20 patients were studied. 45% of the cases were bilateral. There was no gender predilection. Most common cause of the CNVM was found to be multifocal choroiditis at 40%, followed by VKH at 25%. The most common symptom that the patients presented with was diminution of vision at 95%, followed by pain at 35%. The mean age of the patients were 35.4 years, and the duration between the onset of uveitis and diagnosis of CNVM was an average of 51.5 days. The duration of follow-up was an average of 1,533 days. The number of inactive cases of uveitis developing CNVM was 10, and the active cases developing CNVM was also 10. Coming to the treatment details, all patients received steroids, 12 patients received immunomodulatory therapy, and 4 patients received ATT. The most common anti-VEGF used was bevacizumab, followed by ranibizumab, and an average of 3 injections was found to be sufficient to control the activity. 22.6% of the involved eyes showed no recurrence, and 16.1% had only 1 recurrence. Only a single patient had more than 3 recurrences. The most common complication found in our study was raised intraocular pressure, which was seen in 57.1% of the patients. Peripapillary choroiditis is the most common cause for developing CNVM. The possible cause is due to widening of the potential space between Bruch's membrane and the swollen optic disc due to the chronic inflammation, and deformation of the peripapillary Bruch's membrane due to chronic disc edema, which can lead to breaks. In our study, the most common non-infectious cause of the peripapillary CNVM was multifocal choroiditis, followed by VKH, whereas in other studies, it was seen as VKH and punctate inner choroidopathy. Tuberculosis was the only infectious cause that was found in our study, whereas it was tuberculosis and toxoplasmosis in other studies. Our study showed no gender predilection as compared to other studies. Posterior uveitis is most prone for developing CNVM, either in active or inactive conditions. So activity of the underlying inflammatory condition is not necessary to develop CNVM. Peripapillary CNVM has a tendency to extend either around the optic disc or towards the macula, and hence it is essential to manage prior to the extension to prevent irreversible damage. Bevacizumab was most commonly used to treat the CNVM, and the reason behind such an inclination was mostly due to cost factor as well as easy availability, which can cater to most of the Indian population. D'Souza et al. In their study also found a predilection for peripapillary location of CNVM as opposed to the Western population. Only one eye had more than 3 recurrences in the disease course, and the rate of recurrence reduced after instituting immunosuppressive agent. So this case highlights the role of immunosuppression in peripapillary CNVM, at least to reduce the recurrence as well as the complication rate. Currently, there are no guidelines for their use. The most common complication found in our study was raised intraocular pressure, which could either be due to the steroid response or due to multiple intravitreal injections. Limitations of the study was that it was a retrospective study design, and all the patients were referrals being a tertiary eye care hospital. Coming to the conclusion, peripapillary CNVM is a serious complication associated with any uveitic condition. Early recognition and appropriate treatment is the mainstay of management. Till date, there have been numerous studies on diagnostic as well as therapeutic challenges of peripapillary CNVM, but there is no study on the clinical profile at risk of developing such a complication from India. This naive study is the first from South India, elaborating the clinical profile of such patients at risk. However, due to the role of immunosuppressive agents is yet to be studied in detail by randomized prospective large-scale studies. These are my references. Thank you.
Thank you, Dr. Aarti. I would request all the participants to quickly come up for a photograph. And thanks to Dr. Ajay, Dr. Geetanjali, and all the speakers. Thank you very much.